A very warm good afternoon to everybody. I am standing in for Dr. David Rosario. His mother was admitted in the ICU and he couldn't make it. Our prayers are with him. But I'll be speaking about rotational atherectomy in complex PCI. How do I do it? So we know that the interest in rotational atherectomy in the past decade has really increased because of the more and more complex procedures that cardiologists like all of you are now doing. So the objective is to provide some points of protocol and precautions in this. First of all, what are the indications for rotational atherectomy? Definite indications are very severely calcified lesions, typically 360-degree calcification, napkin ring calcification, calcifications showing reverbation in IVUS, device uncrossable lesion, IVUS and OTC catheter cannot cross. Possible indications are also moderately calcified lesions, which we are looking at. What's a definite no? We normally do not like to do it in patients who have a large thrombus burden or an extensive dissection, or lesions which have a lot of angulation, as we were discussing, or bypass graft lesions. How do I select the wire? So for all purposes, most of us use a floppy rota wire, but there are instances in which you would like to use an extra support wire. And what is that? If you have a very severely calcified plaque, you've used a floppy and you're still not able to ablate it, you can shift to an extra support wire. If you have a very tortuous coronary artery and you want it straightened out, you can shift to an extra support wire. If you want to strengthen the backup force in the system, you can shift to an extra support wire. And if you want to shift your point of contact, your floppy wire isn't working, you can shift to an extra support wire. Guide catheter? Well, normally when I do rota ablation, I take a 7 French, but there are a lot of people who take a 6 French, and that's good, because even with a 6 French, you can take a 1.75 burr. But if you're going in with a burr of 2, you would need a 7 French guide at least. A lot of operators make side holes. It's not recommended because your burr might get stuck in the side hole. The choice of the guide catheter curves varies as a preference, but you want coaxial positioning of the guide, and that's very important to remember. What is the appropriate burr size? We were talking about it. You need to have a burr size between 0.4 to 0.6. So there have been comparisons of small burrs versus large burrs, and we've seen that with large burrs, you only end up with more complications. The small burrs work well, so 0.4 to 0.6. This was the STRATA study to determine the rota ablation and transluminal angioplasticity, and they found that a routine strategy is better than aggressive debulking. The question is, to burr again, and when do I do that? Well, when do you want to size down? When your first burr cannot cross the lesion. I'm having a lot of flickering on this slide, if someone can help me with that. So if your first burr cannot cross the lesion, the operation needs to size down with the burr. When you want to size up, so if you're planning to use the big burr but you have a very tight lesion, so you start with the small and then you can size up. If you have gone in with the first burr and then you've done an IVUS imaging and you find that you don't have enough lumen, then you would want to size up. Also, if you've burred and then you've taken in a balloon and you still see that there is dog boning happening, you want to go up with a higher size burr. Burr manipulation, rotational speed. It varies widely. What do I commonly use? I use a 180,000 revolutions. But what is recommended? If you're going low speed, 140. If you're going high speed, it's 190. Usually, the important thing is, at whatever speed you can control the burr, that's important. Avoid excessive rotational speed down. Do not deactivate the burr within the lesion. And do not deactivate it beyond the lesion. And use time limits of less than 30 seconds. That's important. There's also a slow rota system which we use. We run the rota at 120. And when we use it at that speed, it's basically to increase the MSA. How to bring the burr to the platform? It's important that you don't take the rota wire too deep or to be pulled back. It may make a loop at the outside of the guide catheter. Now, the manufacturer recommends to use the Dynaglide mode only when the operator removes the burr, but a lot of them use the Dynaglide mode when they bring it burr to the platform. Both ways have some advantages, some disadvantages. So, when you're going Dynaglide mode, the extent of resistance is less. The wire does not tend to advance more distally. The wire tends to be pulled back when the operator advances the burr. No, that usually doesn't happen in Dynaglide. Possibility of making a loop outside the catheter when you're taking the burr in. That usually doesn't happen when you have the Dyna mode on. And the combination between the operator and the second assistant is not so important when you have the Dyna on. The jumping phenomena is rare, but there is a possibility of damage to the guide catheter. Rota cocktail, a lot of people use a lot of combinations. What we normally use is a nicorandil, heparin, nitroglycerin, and saline. Imaging devices, yes, very appropriate to use IVUS because you can actually size your burr, you can actually decide which rota wire you want to go in with. So that is very helpful. And the risk of complication is usually less if you use an imaging device. Comparison of IVUS versus OCT in this, the strong point is if you're using IVUS, it does not need to eliminate the red blood cells and you can use it safely, even when you have a dissection and hematoma, because the chances are there when you're doing a rota. The weak point with IVUS is it cannot prove the thickness of the calcification. So basics of rota ablation, don't push, use pecking, it avoids trenching, runs should be short, avoid rapid advancement, avoid stopping or starting the burr within the lesion, avoid stopping it distal to the lesion, avoid adjusting revolutions per minute during the burring, and avoid burring in the guide catheter. Finish with one polishing run, and when you have no RPM drop and little or no resistance. When do you say it's the end point of a rotational atherectomy? What's the end point? Well, the end point is when the burr crosses the lesion without any resistance and no additional speed down is observed. Of course, when we're doing a modern PCI, we can just image, see all the cuts in the calcium. Complications, very interesting. People are generally scared of rota because of the complications which can occur. Slow flow, one of the most common complications. 5 to 20% of the patients have slow flow. And the lesion length and the burr artery ratio, these are reported as the determinants of slow flow. For prevention of slow flow, have an appropriate burr size. Do a short ablation run. And gentle manipulation is required. And wait in between the runs for the flow to occur. Let me show you a complication. This is a case I was doing in a live workshop. 51-year-old male, diabetic hypertensive, last 5 years, angioplasty to the RCA 4 years ago. Symptoms record, ejection fraction 30%. Angiogram revealed a circumflex osteoproximal 90% long segment disease. LAD is calcified 80%. The RCO is a CTA, it's an instant restenosis. He was advised for a bypass surgery. The patient said no. Now this is the RCA CTO, and then you can see the circumflex. Then you can see a long osteoproximal disease. And the circumflex, the problem was the circumflex. It's a bad disease in the circumflex. So we went in with the rota in the LAD and we stented it. Fine, that went well. We did a stent and a post-dilatation and everything was okay. Then I downsized the burr. Instead of a 1.5, I took a 1.25 and went into the circumflex. And you know what happened? This is just a 1.25 burr. And immediately after the rota, there's no flow in the circumflex. And in addition to that, there is a haziness in the LAD osteum. So, and this is followed by no flow in the LAD and the circumflex, and this is followed by cardiac arrest. He was revived by daughtering in the LAD, a low pressure dilatation in circumflex, liberal use of nitroprusside, NTG, Nicoran, shifted out, we put in a TPI, we put in an IABP, ventilated the patient, took him out. Revived. The reason for this phenomena, why did it occur? It occurred because of microvascular embolization of atherosclerotic debris, thrombi, platelet activation, vasoactive mediators associated with periprocedural MI, and the microcavitating phenomena directly relates to the rotablation speed, the burr size, and the duration. Technical factors: larger burrs, longer runs, sudden deceleration, optimal technique of flushing, antithrombotic. In this case, there was embolization in LAD from the shoulder of the burr, which caused slow flow in the vessel, leading to the catastrophe. So, next day, we took this patient up, completed the procedure, stented the circumflex, delivered, deployed smoothly post-rota. This was the final result. The RC, ISR, CTO was also dealt with in the same setting. LAD in case was the side branch, as it was the ostial circ with short left main. So it's important because you cannot keep the secondary protective wire when you're doing rota at this point. It's also important that if you can, please position the burr distal to the takeoff of the side branch. Team, can you check my mic? Thank you. So chances of companion or side branch embolization. So we're a little short of time, and this is a longish presentation. So a lot of other complications which we deal with on a daily basis, including perforation, including entrapment of the burr, which sometimes give us a bad situation, but you can deeply intubate, or you can take in a second guide catheter, put in a second wire, mobilize the burr, and take it out. It's very important to be careful about the rotational speed reduction, the sound of the ablation, and the resistance during the burr manipulation. Also, transaction of the rota wire. Remember, if you take the rota wire very distally, it can transact. And the radio opaque of the wire can be seen, but the radiolucent portion of the wire is usually not seen, and you might miss the transaction. So be very careful, or we end up with perfection. RC ostial lesions are very important for us, because when you're doing an RC ostial lesion, it's very difficult to be coaxial. And sometimes we take an extra support wire in that. This is halfway rotational atherectomy, especially important in complex lesions in which there is angulation, and you would actually like to go halfway and then take in a cutting balloon beyond that. So let me finish it up with a case. 70-year-old male, diabetic, hypertensive, acute inferior wall MI, LAD D1 bifurcation, planned for either an IVL or a rota, and an interval PTCA to the circumflex LAD D1. RC was done, and when we took the LAD, you can see the LAD D1 bifurcation, and the balloon would not expand, so we had to take in a rota. This is a post-rota. We did a cutting. Subsequently, this is followed up. We did a LAD stent. This is followed up by a dilatation, a kissing balloon, a pot, and then a Q-lot with the D1. I'll just show you the final kissing and the final pot. And then you can see the final result. Post the final pot. And then subsequently we took an IVUS run to see the opposition, the neocarina. So the old adage in medicine is that an ounce of prevention is worth a pound of cure, and this holds especially true for intervention cardiologists who are using rotational atherectomy. Ladies and gentlemen, thank you so much.